Hello, everybody. Welcome to another episode of Data Doesn't Equal Outcomes. I'm your host, Tristan Keelan. Behavioral health and human service organizations have to demonstrate outcomes. They have to run programs that make people better and prove it. And so the mad scramble for data is well underway. But data is just numbers, outcomes are just results, and connecting the two is the work. So if it has to do with driving better results for clients using a data-driven approach, we cover it here on Data Doesn't Equal Outcomes. My guests today are Dr. Patricia Nellius-Guthrie, the Executive Vice President of Innovation and Knowledge Management at the Florida Coalition for Children. Also with us today from CCNY, Executive Director Heidi Milch, and CCNY partner Ann Boughtin. Hi, everybody. Thanks for joining us today.
Good morning.
So today we're here to talk about a couple of topics that are separate but related. Change in the era of COVID, as well as the Family First Prevention Services Act, or FFPSA, as it's become affectionately known by its acronym. But before we get started, I want to ask Dr. Nellius-Guthrie to introduce herself and her organization and see if we can maybe get a little history from your perspective on the foster care and residential system that led us to the Family First Prevention Act.
Absolutely. Thank you, Tristan. And it's a pleasure to be here today with you and your audience. I work for the Florida Coalition for Children. We are a membership association that represents 50,000 children and their families in the state of Florida, and we have close to 100 member association members that consist of service providers and community-based care lead agencies. So, and prior to that, I was a child welfare leader and consultant as well. It's interesting, I think that in many ways, the Title 4E waiver, the federal Title 4E waiver, served as almost as a pilot demonstration project to for the nation's child welfare system, replicating FFPSA in many ways. There were a lot of innovations that surfaced as a result of the federal 4E waiver, and it freed up the funding to allow flexible use of funds for states and counties and jurisdictions to be able to innovate. So now, as we think of what's transpiring with FFPSA, which in many ways it's different than the 4E waiver, but it is a step closer to bringing the entire nation to having more flexibility and more focus on prevention. I think, in my estimation, the origin of FFPSA came out of resulted as a number of factors. Number one, I think it was the growing voice and presence and the advocacy movement of those with lived experience who gained the attention and sympathy, if you will, attention of members and sympathizers, if you will, of Congress and their congressional staff, who really joined with them in championing reform. And that happened, I think, over the course of a number of years at the Congressional Caucus on Foster Youth. Now, you had the Congressional Caucus on Foster Youth with youth coming and really sharing their lived experience in the child welfare system alongside of national advocates, organizations that were very invested philanthropically in advancing and supporting, the and strengthening the child welfare system across the nation. So I think that had a lot to do with it. And then just the general need to modernize, our system that had been operating very similarly for decades. And so there was a real need for that to occur. So in my estimation, I think it was an incentive to move from historical practices to modernized practices, almost with the 4E waiver serving as a pilot demonstration project so that those with lived experience could pave the way from their experience alongside of those philanthropic leaders and then help to mobilize and manage the change, particularly fiscally, to move upstream and focus on the areas that were most important to develop our systems and change our systems.
Yeah, so you mentioned this idea of modernizing some of our practices. Can you give us just a few of the core tenets of Family First and how that differs from history?
Sure. Well, number one, there is a strong emphasis on the use of evidence-based practices. And so, I had forecasted a number of years ago, probably back in 2007, and started actually a pilot project in my organization where, funders were going to start requiring outcomes and evidence that what we were doing for kids and families was working. And so, I had suggested to my organization that it's very difficult to shift to evidence-based practices because of the degree of rigor that's associated with them and with implementing them. And yet I could foresee in the near future that funding was going to be tied to the use of, evidence of outcomes, value-based contracting, if you will, in many ways, right? So I think really what we're talking about is, a system that is using evidence-based practices, showing that what we do is working, moving towards, I guess you can call it right-sizing group care, where there's an emphasis on kids and families being in the most family-like environments, and less use of residential type of facilities. This is, all outlined in FFPSA. When children do have more acute needs, then the qualified residential treatment programs have very clear parameters around the staffing and the credentialing of the staffing that would be serving them and the period of time at which they would be placed in that facility, expected to make progress and to, heal and thrive and move forward in a more family-like setting. And then you really have a strong emphasis, which we saw a lot with the Title 4 waiver, a strong emphasis on moving upstream and building front-end continuums of care so that we could keep kids and families, safe together at home and in their communities. And we could do it, without necessarily being involved in the judicial side of services in the child welfare system. And then where there's an emphasis on kinship navigation services and kinship care, because, there's a lot of kin in this country that care for their children. And so there's even funding that's made available now for relative caregivers, nationwide, and an emphasis on really locating those caregivers.
Right. Thank you for that overview. So you have kind of a realigning of funding, right? One of the most historic realignments of funding for these type of services. Where do you see the current state of implementation? I know that's a very broad question and varies by geography, but in general, what's your take on the state of implementation?
Well, if that question is posed to me, Tristan, Family First was enacted in February of 2018. And, it was staggered over time. It gave transition time for states to begin the pre-planning, the planning processes, and anticipate how they were going to roll out. And of course, midstream, the final date of requirement, which was October 1st, 2021, we had COVID. So, all things considered, right, I think we are exactly where we should be and where we need to be. I tell my colleagues nationwide that FFPSA is not an event. I think a lot of people, when there's a date, we think it's an event. October 1st, everything's going to change, and October 1st, everything didn't change. That was the date that we really needed to sort of see that the environment was shifting to the new, requirements enacted in law. Where we currently are as a state and as a nation is that we have a lot of the evidence-based practice programs being submitted to the Prevention Clearinghouse to determine their status as either well-supported, supported, or promising. And so there's that work. And interestingly enough, that's a pretty rigorous process. So I think we're going to build capacity for those evidence-based practice services over time. And then we have 22 states also comprised of tribes that have approved Title 4 prevention plans. So those states have met, they've done their pre-planning, they've got their plans submitted to the feds and approved by the feds, and they're moving forward now with rollout and implementation. And then we have another 21 states, and tribes who have submitted their plans. So all told, there are 43 states or tribes that have, drafted their plan or received an approved plan. So I think that's a good sign, And so we're moving forward in a positive motion, slow and steady progress, which is where we should be with reform of this magnitude. And really, communities of practice, they're now beta testing and piloting what they conceptualized in their plans to see if what they conceptualized when they operationalized it, is where they perceived it was going to be. Is it producing the outcomes and results that they perceived it was going to? Or do they need to tweak, their concepts and policies and all that's associated with that to be aligned with, the rollout and the implementation. So I think we're in a good place. Many states and communities are in the process of selecting their EBPs, implementing and rolling out their EBPs, redesigning their systems of care, training, creating front-end prevention, upstream continuums of care, and then focusing on their legislative changes that are required as a result of FFPSA and their policy and practice shifts.
What a really great way to sort of sum it up. FFPSA is not an event, right? I mean, this is such a great step back to say, no, this is a shift in thinking. This isn't a light switch. We don't flip it. We start making progress, and that's exactly what we're doing. You talked about evidence-based practices, and that's the direction that we're going to take this discussion in next. And we'll open these questions up to the group here, but let's just start with sort of what is an evidence-based practice and how do you implement it?
So who's going to take that question? Is that directed towards me or Anne or Heidi? Would you like to respond?
You want me to do it? So an evidence-based practice is one that has been rigorously measured over time, and data and program evaluation proves that the outcomes are achieved if certain steps are measured and certain interventions are done in a certain pattern, in a certain way. And they receive the designation of an evidence-based practice through that rigorous evaluation, usually a quasi-experimental design or an experimental design where you can test the outcomes against a control group to make sure that implementing an intervention in a certain way works.
So then we have this issue of fidelity to the model, right? And making sure that an evidence-based practice is not only chosen, but being followed as prescribed. How do we know and how can we tell that we're following the evidence-based practice that we've chosen?
So in order to know that, organizations and programs have to measure their fidelity to the practice, meaning there has to be data and measurement that looks at both the process and the outcomes of the intervention being delivered. I liken it, this seems simplistic, but a good way to think about it is if you go to Starbucks, they have a process through which you order a drink. It should be the same drink received every time. That is the main theory of fidelity to an evidence-based practice. If a child or a family receives an intervention, it is done in a certain way that the outcome is positive at the end of that intervention. If you have potentially a new barista who has not been onboarded correctly and you place an order and you ask for a couple changes, what you get at the end, that coffee looks a little bit different. It might not be horrible tasting, but it is a little bit different. So if you look at it that way, although that's very simplistic, that's sort of the thought behind measuring fidelity and having fidelity to an evidence-based practice.
I think that's a really good point, Heidi. It's important to note that during the early adoption and implementation, which we are as a mass, right, as a collective nationwide, you can expect the competency and proficiency of practitioners as they grow, they're onboarded, they develop in the practice to improve over time. And so it's important when you're implementing an ABP that you account for that. How long is it when someone is on board, trained, and now out in the field that you expect the results of their work to improve. And, really, to piggyback on what Heidi said, I look at fidelity as crosswalking the adherence, the degree to which the adherence to the practice is occurring. So all of the components of the model program, the degree to which those, elements are being carried out, that's fidelity. And the degree to which there's variance, that's a lack of fidelity.
I also think in regards to evidence-based practice, when they are being implemented or newly implemented, there's not always a lot of attention paid to the organizational requirements, not just the practice requirements, but organizational culture changes that need to be made in order to support an evidence-based practice. There's a lot on the organizational side in terms of coaching and supervision, electronic record and other infrastructure that really needs to be in place to optimize implementation and sustainability of an evidence-based practice.
As was mentioned, a lot goes into it, making it difficult to implement. Anne, go ahead.
Your analogy, Heidi, of Starbucks, the evidence-based practice really starts with the customer. You come in and you place your order. That's analogous to addressing the needs of the children and families that your organization is serving. So when you choose an evidence-based practice, it's not just choosing an evidence-based practice, but it's choosing that EBP based on the needs of the population that you serve. When you look at cohorts of children and families that are in the system, they're not identical. They vary geographically, they vary demographically, they have a variety of needs. So I think the need for data to inform the choice about the evidence-based practice starts before you get in line at Starbucks. You have to know who your customers are going to be. And I think that's where data needs begin. It's the evaluation of who you currently serve. So you can make an informed choice about selecting the evidence-based practice. Because if you're expert at serving espresso and what the majority of your people need or want are lattes, your outcomes are not going to achieve the changes that you're hoping for under Families First. So probably every organization currently has some level of data. They're probably drowning in it. But if it's not sorted and evaluated in a way to inform that choice about the evidence-based practice, all the training in the world and all the cultural changes you make organizationally won't move the needle for the people that you're serving. So I think, for years we've heard right service to the right children and families at the right time for the right outcomes. Historically, that's been based on what some of us call clinical moxie, what you think is the best thing for the best intervention and support that you can provide to those families. We have clearly moved with COVID and some of the new federal initiatives, whether it's on the child welfare side or on the mental health side, we have clearly moved to data-informed decision-making at all levels of the organization. And that becomes the starting point. And the outcomes are key, as Patricia said earlier, for value-based contracting. You have to have the value proposition, which is based on not only the clinical outcomes linked to the evidence-based practice, but the costs associated with that to provide the value proposition for value-based contracting. If you spend a lot of time on the wrong people and your costs are very high, you're not going to have a very good value proposition. So it might be the wrong people, wrong service. You have to balance all of those factors to make sure you're achieving those kinds of outcomes.
Yeah, I think that brings up a good question when we talk about entry into services. So we've got evidence-based practices. There are multiple chosen by the right providers for the right reasons. But what about our courts and our single points of access and sort of getting people to the evidence-based practice that'll best serve that need? Patricia, can you help us understand sort of the stakes, if you will, of sending somebody down? It's an EVP, but if it's not the right one,
Sure.
what does that mean?
Well, to piggyback on what's been discussed so far, really what communities during this pre-planning and planning phase need and have done, right, is an analysis of needed capacity. They already have, or a gap analysis, if you will. They already have their service array. Now there's FFPSA. We're moving towards evidence-based practices. To what extent do we have those evidence-based practices or elements of them within the community of practice? And then where are the gaps based on the demographics and population, like Ian said, that, we don't currently have sufficient capacity of. And then as you start implementing those, programs, and you have a full array within a community, right? A full array of services that are available and accessible to families. Now you really need to differentiate either through some kind of a decision tree, some kind of a guide, so that, those that are out in the field, whether it be the judiciary, whoever the referral source is, that they can clearly identify the profile of the population and the corresponding services that are available to meet the needs of that population. And so, it seems fairly easy, but it is more complex because of the degree of turnover in our community, in child welfare particularly. So there's this need to have these concrete tools accessible, but to embed that training in the system continually, so those referral sources, understand that you just don't select any service, and throw it at the child and family, but you're being very, calculated and strategic to make sure that the service that they've identified has been designed and created and proven effective with that population.
It makes me think of the Starbucks analogy that we've been going with. If your practice makes a latte and it makes a great latte, that doesn't help if the client needs a fruit smoothie, right? And so making sure that we're delivering that. Anne, love to hear your thoughts.
Well, I think there's another dimension to this, and it starts back with who you serve well. What are the hallmarks of your organization? It's not just the particular service. There are a lot of, for example, residential service providers. That said, some of them serve very different populations. So being able to associate the name of the organization with the kind of population that you serve best becomes part of, I hate to sound businesslike, but the marketing or the hallmark of who you are. So that when you get referrals, you get an appropriate referral that allows you to intervene quickly, appropriately, and help that family to achieve an outcome sooner. So using your data and your information to basically create sort of the 30-minute elevator speech, because referring agencies are not going to be as familiar with the evidence-based practices as they are with the unfortunate labels that our children and families get of certain profiles. So using those more common names or descriptors is a better way to put it. The more common descriptors is a way to really make a difference for children and families and provide timely access and earlier interventions, because it is the right service at the right time.
I think what you're talking about, Anne, also brings up another point, that in this environment, the business side historically has impacted the decisions in how organizations are marketing and the choices of interventions that they provide. A lot of organizations, the larger organizations, were used to being all things to all people, send everybody our way from a business perspective. And this really forces an organization to be brave and take a risk and say, that's not our forte, but this is, and maybe partner with other organizations to fill out a continuum in a business, from a business perspective, partnering versus being all things to all people at all times, because that won't work in this environment.
That's a really good point. Oh, I'm sorry, Tristan.
Okay, I was just going to say for those agencies, the larger agencies, it might mean educating on your program, not just on your agency as a whole, right? Referral sources need to know your various programs. Patricia, go ahead.
Yeah, I was going to say, in response to what Heidi was saying and Anne was saying, I think what FFPSA has done is really force the child welfare and mental health business community to look at the population that is served and look at where their specialty is, if you will, to designate the specialty services that they provide and rethink how they deliver those services. So, if the nation is going to right size group care and 90% of what I do is group care, and I want to stay, in the service of children and families, then from a business perspective, I need to begin to recalibrate my business plan and maybe do more community-based services, more front-end services, respite services, those kinds of things. The other thing that there's been a lot of discussion around nationally is that I think there is sort of a traditional group care milieu approach, that a child needs to be placed in a traditional group care setting. And now I do think we're pivoting towards a real specialty designation. So what population is your milieu going to focus on, and what is that clinical model going to look like for that specific target population? And the more that occurs, I think the more enhanced our continuum will be as we shift and pivot to this new norm of FFPSA.
I think you make a good point, Patricia, in that we're looking more at the needs of the population. Historically, from a public policy perspective, government has funded programs and then parse those programs into specialized programs. I think where we are moving now with this population approach is it's not about the program. It's about the treatment intervention that you're providing to a particular population or a particular youth or family. And it's that intervention that makes a difference, not the milieu overall of a particular program or all of the services that have been included historically under a license that you might get from the government. The second piece here is knowing who you serve well is extremely important. I was working with a nonprofit just last week who said, well, we're waiting for the state to come out with a policy, define, or we're waiting for this agency to bring up this service so we can build out the system of care. And this is not an environment in which you can wait for direction, which I think nonprofits historically have done and having, grown up in the nonprofit industry, we have a puzzle piece and we wait for the frame to come out so we know where we fit in the puzzle and we make sure we fit in there neatly. Now what we need to do is build our own frame and then take the pieces that come in the community and build out the puzzle for the population that we serve so that we become the hub. We are not the spoke waiting for the government or some other organization to say, yes, we need this spoke to do this, and we'll pay you for just that spoke. It's not going to be like that anymore, I don't think. Patricia?
No, I absolutely agree. And I think, in addition to that element with FFPSA, and this is interesting because I've done, the promotion and inclusion of those with lived experience work since the late 90s. And it's been a very slow progress and truly having authentic youth and family engagement. FFPSA changes that. It was those with lived expertise who really helped move the needle, right? And I do think that as we are moving forward, as a national community of practice, as a system of care, that we're going to be informed, led, and guided by those with lived experience to really play a significant role in the work that we're doing and the effectiveness of the work that we're doing, and truly having them at the table as authentic partners, not as a forethought, not an afterthought, maybe as has historically been the practice.
The word that you said that jumped out to me is authentic. So as we bring on more peer supports and people with lived experience, we have to make sure we are listening to them, not dictating what we think their role should be, but truly listening to their lived experience and how does that apply to quality improvement and how can we put that into system change. Truly listening and supporting their needs in this process, because it's a change for both sides, I think is imperative.
I think your use of the word
talking
process,
about lived.
Go
ahead.
I think your use of the word process is important, Heidi, because we've talked about the importance of having the data early on to know who you're serving, using that data to select your evidence-based practice, monitoring your evidence-based practice for fidelity to the model, and then implementing a continuous quality improvement cycle, because as your families gain strength, power, and adapt to the changes, their authentic voice may speak to us differently, in which case the CQI process needs to be ongoing. The continuous quality improvement needs to reflect the changing input. So we can't think of these things as isolated, like the data around who you serve, the data that you collect through ongoing interventions. Are we practicing with fidelity to an evidence-based practice? An evidence-based practice is a singular intervention. My sense is that notwithstanding the evidence-based practice, there are other interventions and supports that the family might receive in addition to that EBP from the system of care. So that CQI that measures not only the evidence-based practice, but looks at some of those additional supports, services, and external influences becomes an important part of how you continue to keep your agency in a strong position to make a difference for the children and families that you serve.
I think one of the things you're bringing up, Anne, is important, and the buzzword of social determinants of health. If you're working with a family in preventive services for child welfare, you can have the evidence-based practice that in theory is supposed to work, but if they are housing insecure, food insecure, and all of these other services and processes that should be put in place, there will be an impact on the effectiveness of the evidence-based practice.
That's a great point, Heidi. And I've sort of developed a cliche where I call it the social determinants of entry into care, right? You have all these other factors that in and of themselves do not warrant entry into care. And so now I think as we're moving upstream, we're really beginning to pay attention to, housing insecurity, economic insecurity, food insecurity. All of those factors do not warrant and justify removal and entry into care. And so now I think that is one of the real value adds that FFPSA brings to the table in helping us shift our practice, shift our culture, shift the way we think about those that we serve.
Talking about lived experience, I want to talk about our common lived experience for the past couple of years with COVID and navigating services amidst the pandemic. And really, we touched on it earlier, but the timing of FFPSA and COVID really took the focus away from the largest funding restructuring in child welfare services history. A substantial effort got undermined by a global pandemic. So, Patricia, how do we level set against COVID and kind of, reconcile with the disruption to move forward?
Yeah, the disruptive force of COVID. It's interesting, Tristan. I think COVID contributed towards maybe pushing the pause button at the pace at which jurisdictions were moving in pre-planning and planning for FFPSA, but in some ways it accelerated the work that we're doing. And so I think the challenges, the barriers, and the obstacles that COVID presented to society as a whole caused us to innovate at a pace that I think wouldn't have happened for decades. So if you just think about the, widely accepted use and practice of telehealth now, and interestingly, some of the outcomes, the positive and favorable outcomes that the COVID induced telehealth platform, Zoom platform, all the changes that we made really revealed to us. I know that I was in a meeting not all that long ago, maybe a year ago, and we were doing sort of early anecdotal evaluation of the impact of COVID. And the educational community that was represented in this meeting indicated that their school attendance had substantially increased during COVID as compared to under normal conditions. So children participating in virtual schooling, had increased. Another member in that meeting who worked in the mental health industry indicated that there were more families and youth engaging in the family interventions virtually than when they were community-based interventions. So I think that COVID offered us opportunity, a silver lining, if you will, to innovate at a very rapid pace. And I think that, the whole adaptation, the challenge that probably most of us have experienced, and it's going to be the long hauler COVID impact of the workforce, if you will. We hear a lot about the long hauler impact of those who are symptomatic post-COVID, but the workforce has a long hauler syndrome, right? And it really changed the face of workforce. And I think, what do they call it? The Great Resignation, right? The Great Resignation. And now we're thinking differently about, how we employ individuals and the workforce. And so I think in many ways it helped accelerate and get us to look as a society at things differently that we needed to look at differently. And now we are, moving forward in a stronger place, better educated, with that lived experience that we all share together. So that's sort of my, response about that. Change of this magnitude is monumental anyway. And so it requires a well-coordinated, strategic, and planful approach. And we just got immersed. When I lived in Canada, all my kids went to French immersion because they were English first language, right? So we got immersed in this new norm of FFPSA post-COVID.
I think you make an important point here, and it's something that's often overlooked. When we talk about evidence-based practice and the children and families that we serve, it is the group that we, the system, have successfully engaged. And engagement is key, absolutely key to early intervention. And I think, to your point, Patricia, now that we can do more through telecommunication, we're able to engage families earlier. We're able to keep them engaged. For years and years, we talked about parents who worked and couldn't support their kids in their treatment process because our hours were always during the day and we only had them evenings and weekends. Now, evenings and weekends become much more accessible to families, to working families who have to work outside of the home. And I think, the engagement of kids in school becomes important. We talk about it, but external to our treatment and service system is the educational system, which is often the first place where children are identified as being in need of services. So our ability to partner with teachers and to not have that just be the big event when we're doing an IEP, an individual education plan for a child that involves the school, the mental health system, the child welfare system. This is something that can be much more readily facilitated earlier with, an opportunity for regular reinforcements of the staff in terms of the progress that the child is making, the needs for support that the family needs at that point, and having those conversations happen regularly so that we not only engage at the front end, but we keep families engaged and the youth engaged as they move towards their positive outcomes.
I was working with a children's services provider, and the seasonality was very evident in the data historically, right? That during school months, service levels were higher, referrals were higher, teachers were able to intervene, and there was always a service lull throughout the summer months. And the introduction of telehealth flattened that line, and they weren't losing kids, and they weren't losing engagement over the summer months just because people got outside, weather got nicer, which tend to, give people every reason not to attend, counseling sessions, and telehealth really flattened that line. It was nice to see. So I want to do one final thing, and I want to hear from everybody. And so we'll take turns, but this is a lot of change happening, and a lot of change happening all at once. So if you had one piece of advice for an agency trying to push through all this, you get 15, 20 seconds, like Ann likes to say, with an agency on an elevator. What do you want them to know? Patricia, I'll start with you.
I think it's really important that you predetermine critical junctures, that you're going to stop, push the pause button, evaluate what you conceptualized as compared to when it's operationalized, and intentionally and strategically, make any adaptations that need to be made instead of just moving forward because the policy and practice has been implemented. Really look at those critical junctures and make those changes because, during that visionary period, there are always unanticipated obstacles, changes, shifts, a myriad of things. So to just give yourself permission as a system to evaluate, not look at it punitively, and make those adaptations and move forward at that point.
Excellent advice. Ann?
I think organizations need to identify their true north. Who are they going to be in the next 2 to 5 years? And to establish their data collection as the basis for how they're going to support the change. In establishing the true north, you cannot deviate from your implementation activities, having your implementation activities support that. And communication becomes key in these situations in that you need to speak to your staff about the changes that are coming, not only speak to them, but speak with them so you can get their feedback and their perspective on what changes they think are necessary. And as we spoke before, to have lived experience partners be part of that conversation. If you approach the change as a mere process of compliance to check boxes, to get the funding and stay in good standing, I dare say at the end of that, you may be more frustrated than successful because the meaningful change will not have occurred.
Excellent.
So,
Heidi?
my brilliant colleagues said it all, but what I will add is the communication piece for change management is huge. So I would suggest agencies put this in a PDSA quality improvement model and use the Plan, Do, Study, Act with your data to select, implement, monitor. And what Ann said is so important. You have to communicate with your staff. The frontline staff and managers are the ones implementing this change. They need to be included from the beginning and listen to their perspective. And that is somewhat of a change from traditional practices. But if you use a PDSA model, you will stay on track, you will use your data, and you will incorporate the people that you need to hear from.
Well, there you have it. Excellent advice from the best in the business. Thank you all for joining me today. This has been an episode of Data Doesn't Equal Outcomes. My guests today have been Dr. Patricia Nellius-Guthrie, Heidi Milch, and Ann Boughtin. This has been a conversation on change in the era of COVID and the Family First Prevention Services Act. Thank you. Have a nice day.
Thank you.